To reach the diagnosis of MSK lesion, first of all, you want to get high-quality images of the bone, of the soft tissues, as well as the metal hardware. But you might also want to get functional approach to the lesions, including perfusion studies and kinematic studies. Do you know any tool which would provide such an evaluation with a fast and a reliable technique, easy-to-use technique? I know only one technique which would provide all these elements. This is the wide area detector CT scan. This technique is a breakthrough, a disruptive technology, and this technique provides brand new application which clearly modifies the diagnostic strategies in the MSK field. And during this presentation, I will show you some of the examples of the application of this technique. One of the applications of this technique is a perfusion study, which can be used for the depiction and characterization of bony and soft tissue lesions. This is an example of a glomic tumor, and this lesion is less than 1 centimeter wide, and we can clearly depict this lesion, localize this lesion, and see the highly vascularized pattern of this tumor. So with this technique, we can depict and characterize the lesion, and you can see that it is a tiny lesion, and the vessels which are feeding the lesion are even much smaller. We can also perform kinematic studies, and in this case, we can clearly see the cause of the result of the patient. And you have the comparison here of what we can see with dynamic CT scan and during the operation, during the operative maneuver which has been performed to show the cause of the result. So we have a very good correlation of the cause of the result depicted with CT scan and with the dynamic maneuver. So this is a clear innovative application due to a wide area CT scan. Of course, we have to do better if we want to separate a normal motion from a pathologic motion. We have to be able to make 3D measurements and even more 4D measurements. For example, this distance, which is defined on the 3D image between the talus and the calcaneus bone, is automatically measured during the motion of the patient, and we can get a curve of the distance which is different during the motion of the patient. And this type of curve will help us to depict the abnormal types of motion. This is mandatory to make a dynamic evaluation. It is also mandatory to be able to depict the metal hardware and the alteration due to metal hardware, and to differentiate all the alteration due to the metal displacement and the collection due to metal hardware complication. And this is the case, for example, of a patient with a dislocation of a hip joint implant. And you can see on the axial image very easily where is located the metal bag from the polyethylene, from the collection, and the metallosis. No other technique so far is able to provide you such an amount of precise and useful information. The new metal-based iterative reconstruction technique is also very useful in MSK because it reduces the amount of metal artifacts around the small pins and the small screws. And in this case of a patient with osteochondritis of the knee, the question was, how is the bone around the screw? Are there some bridges around the screw? Can we remove the screw? Or is it possible to give a status of the fragment? Is it fixed to the bone or not? And with standard algorithm, because of this dark area around the screw, you cannot tell to the surgeon what is the status of the fragment. If you use first with this type of metal hardware, you can remove this black zone and clearly explain to the surgeon what is the status of the bone and clearly show all the bony bridges surrounding the screw, and which occur between the fragment and the spongeous bone. Another very important application that we are using now on a daily basis, on a routine basis, is a new global illumination 3D reconstruction. As you can see here, we can use a high-resolution filter with this type of image. This is not a dry bone. This is a real patient, and you can clearly see the quality of the image and the delineation of each variation of the surface of the bone as well as the spongeous bone. And clearly that modifies the visualization of the subtle alteration of the bone. This is a case with no bony alteration, but these are two different cases of fractures of the spinous processes. And this is, of course, very useful for the surgeon because depending upon the size and the displacement of each individual fragment, the patient will undergo surgery or just will be wearing a cast. This technique can also be applied to the depiction of rib fractures. Using a ribs unfolding technique, you can see all the fractures, all the ribs at one glance. And there is, of course, a wide range of application of this type of visualization because you will be able to depict not only the fractures of the ribs, but also some tumors, multiple myeloma, metastasis, and so on. And you will really save some time, especially if you read polytrauma cases at 2 o'clock in the morning, you want to get a clear visualization of all the fractures at one glance. This is what we get with MPR, specific ribs unfolding MPR, and you can see that with triangulation, you can clearly localize and depict all the fractures. And finally, you can use the new iterative reconstruction algorithm to reduce the dose to get sub-microsievert images. In this case, of a patient with non-incorporation of a bony spongeous bone in the scaphoid, the question was, is there a necrosis of avascular necrosis of this fragment? Are there some bridges between the fragment and the rest of the bone? In the middle image, you can see what we can get using standard CT scan with a low-dose technique, but we can reduce the dose to a sub-microsievert CT scan. Of course, the image quality is not as good as a standard one, but we get all the needed information, and this technique might probably be used in the near future to replace standard CT scan. It will probably, once again, modify the diagnostic strategies. So to conclude, our large detector, a rare detector CT scan is a disruptive innovation because it modifies the different diagnostic strategies. It can clearly compete with all the other techniques to see the bone, the soft tissues, the metal hardware, and in the same time you get a full range of information. And what was surprising using this technique is that when we used it for the first time 10 years ago, it was already a mature technique. 10 years ago, it was already obvious to us that this technique had a clear and bright future in the field of MSK. To conclude, this is not the end of this technique because we know that many new applications are coming up and we'll see them in a very near future. Thank you very much.